In this video, we are going to talk about the case control study, which is important study design that commonly used by the investigators. And as we know that we have four types of case control designs, which is the classical case control and the nested case control and the case cohort and the case crossover. And in this video, we are going to focus on the classical case control designs and the subsequent ones. In the subsequent ones, we'll discuss the other three types in details. Uh, It is a type of observational analytical study designed mainly for testing etiological hypotheses. In other words, testing etiological association uh, between exposure to a certain disease agent and the disease. And it is previously called retrospective studies, but this term is less commonly used nowadays in literature as confusion may arise when we talk about the varieties of cohort study design, such as retrospective cohort study design. And it is better not to use this term for the case control. It is used to identify the exposure that is associated or etiologically associated or suspected to be etiologically associated with the outcome. In general, it is necessary to identify the cases which should be diagnosed as having the disease, and to identify controls free of the disease, and as well as to identify and compare exposure among both cases and the controls. The characteristics of the case control is that both the disease and exposure to the variable of interest have occurred by the time the study is being conducted. By the time of the study is conducted as well, the exposure to variable assumed to be etiologically associated with the disease under the investigation had already occurred. Also, the resulting disease occurred as we are studying cases, and the study direction is thus backward from effect to cause. In other words, we start with the cases and inquire about exposure to the variable under the investigation or the variable suspected to be etiologically associated with the disease. Selection of the controls for comparison, and we have to follow important steps in the design, starting with the selection of the cases and then the selection of the controls and matching of the cases and the controls. Measurement of exposure to the variable under the investigator or the variable suspected to be etiologically associated with the disease or with the exposure, and analysis of the collected data so that to find what sort of association is there between the exposure to that variable and the outcome or the disease, interpretation of the results. We start firstly, we talk about the selection of the cases. Selection of the cases should be based on a specific diagnostic criteria using standard definition, and the researcher should state clearly the diagnostic criteria that he or she is going to use for inclusion of the cases. And for example, if the cases are patients with carcinoma of the breast, then the diagnostic criteria should be spelled out as those cases with a breast proved through biopsy and histopathological investigation, and at which stage of the disease. The researcher should state clearly the cases that are fit or entitled to be selected for the study, and this is related to the eligibility of which type of cases the investigator is intending to include in the study, after fulfilling definitely the diagnostic criteria. Which suitable cases for the study? Are these old or new cases? The requirement that only newly diagnosed cases rather than old ones are to be included for the case control study. This is logic as newly diagnosed cases are assumed to be solely exposed to the variable under the investigation in the past. Although this is not always the truth, as multiple exposure to other variables is a possibility or may occur, and especially that there is always an elapsed time between the onset of the disease and the diagnosis of the disease. And here, there might be possibility of exposure to other exposures that may intervene in some or other way in the association between the exposure and the disease. During this time, as I've said, there might be exposure to other variables which played some role in the etiology of the disease. And this is an important limitation for the use of the newly diagnosed cases in classical case control study designs. On the other hand, all cases are considered not eligible for case control study, as the possibility of exposure to other variables cannot be excluded at all. And the cases are usually recruited from the hospital, and this is a convenient source, especially in developing countries where we do not have efficiently functioning registration system, civil registration system. Otherwise, the cases can be recruited from the from the general population, especially in countries with well-established civil registration system. And the selection of the controls is the procedure through which the researcher selects the controls for standard comparison with the cases. The controls must be similar to the cases as possible, except for absence of disease under investigation. And the assumption is that both cases and controls arise from the same cohort, although this is not always the situation when we select the cases and controls from hospitals. And our assumption might not be true when we assume that both the cases and the controls arise from the same cohort, and some of them they develop the disease and others that did not develop the disease. But it's not always the case, as we are used to select the cases and the controls from hospitals. The researcher can recruit controls from other sources, like, for example, as we have said, hospital controls, and this is the main source of controls. And the researcher can select control from other wards or other departments in hospitals, or from the outpatient clinics, or from the referred clinics. For example, if a researcher is studying the etiological association between the use of contraceptive pills and carcinoma of the breast, and these are the cases, then the researcher can select female controls from the attendants of the dermatology department who are free of breast or other types of malignancies. Relatives. The relatives can be used as the source of controls, and the use of relatives as controls is inappropriate, especially if the disease under the investigation is or suspected to be genetically determined, as we cannot ensure that the controls are free from the disease under the investigation. Neighborhood controls can be used also can be used as controls. Again, the limitation for the use of neighborhood as controls is the possibility that if the disease under the investigation is etiologically associated with factors such as socioeconomic status or environmental conditions, as in this case, in such situation, or in this case, there is no guarantee to ensure that the controls are free from disease under investigation or being exposed to the variables assumed to be etiologically associated with the disease. The general population is another source for the controls and can be used, and this is applicable if we have an efficiently functioning civil registration system. Generally, we need one control is needed for each case, and if the study group or the sample size of the study is small, then we can select 2 or 3 or even 4 controls for each case, but not more than this. And there is usually little marginal increase in precision from increasing the ratio of controls to cases beyond 4, except when the effect of exposure is large, as mentioned by Wash-Doyer S. and al. In his famous article published in the American Journal of Immunology, as shown here. And usually, the best way or approach to increase the precision of a case control study is by widening the base geographically or increase the number of cases temporarily rather than increase the number of controls, because the marginal increase in the precision from an additional case is greater than from an additional control, assuming that there are already more controls than the cases in the study, as I have mentioned in this important reference and this important article. And those who are interested can go back to it and read further about it. Now we talk about matching. Matching, as defined by Porter, is the process of making a study group and the control group similar or identical with respect to their distribution of extraneous factors. And we have several types of matching that can be distinguished. For example, we have caliber matching, which is a process of matching comparing group subjects to study group within a specified distance for a continuous variable, like, for example, for age, maybe matching age up to 2 years, and this can be accepted, as we have mentioned. And then we can talk about the frequency matching, which requires that the frequency distributions of the matched variables be similar in study and control groups. Some also use another term, which is a group matching. Category matching, and this is a process of matching a study and control group subjects in pre-specified categories, such as occupational groups or age group, for example. Individual matching relies on identifying individual subjects for comparison, each resembling a study subject on the matched variable. Pair matching is individual matching, in which study and comparing group or comparison group are subjects are paired. It has to be noticed that the frequency matching, which is also called group matching, necessitates that the cases are to be selected first, and then the investigator should calculate the proportions of certain characteristics among the cases, and this is followed by selection of a control group with the same proportions. For example, if 25% of the cases are males, then we have to select 25% of the controls as males. The goal of matching in case control studies is to balance the numbers of cases and controls within strata that will be used for statistical adjustment purposes. And if the factors used for stratification are associated with exposure, the matched control sample will generally have an exposure distribution more like that of the cases than would an unmatched control sample. Matching will increase efficiency only if the matching variables are associated with both the disease and the exposure. The matching variable must not be on the causal chain. And if high-fat diet is an exposure of interest, we should not match on high cholesterol or vice versa, as mentioned in published articles matching in case control that can be found in the website of University of Illinois. Overmatching, the term originally referred to loss of validity in a case control study stemming from a control group that was closely matched to the case group that the exposure distribution differed very little, as mentioned by Rothman, Modern Epidemiology. Once you match on a factor, you cannot include this factor in the analysis. And we have you have to be assured that you don't want to assess the relationship or the association of that factor to the disease. If you match on a variable that's associated with another variable of interest, then as well you have essentially matched on both of these variables. And this is very important to consider when carrying out matching between the cases and the control. Now we'll talk about the source of bias in case control study. We have the recall bias, as the case of controls may recall the previous exposure to the variable under investigation in a different manner. And as well, we have data collection bias. And here, the data collectors are aware about the cases and the controls during interviewing and recording of the previous exposure. So they will go asking too many questions and trying to generate information from the cases, as they already know that these are cases. So they want to make sure as possible about the exposure, and this can result in some sort of bias. Selection bias, selection of the controls is based on the assumption that they represent the population from which the cases arise. If controls and cases are selected from hospitals and clinics or referred clinics, for example, the representation of the parent population is questionable. We have Parkinsonian bias, which is called Parkinson's bias or Parkinson fallacy. A form of selection bias arises when both the exposure and the disease under investigation affect selection. And this means that in its classical form, it causes hospital cases and controls in a case control study to be systematically different from one another. This occurs when the combination of exposure and disease under investigation increase the possibility of being admitted to the hospital, leading to systematically higher exposure rate among hospital cases than among hospital controls. And the process hence biases the odds ratio that will be a true calculated, it not be a true calculated odds ratio when you select both cases and controls from hospital, because they are systematically different, basically. So the result will be biased. Now we come to the measures of association. In case control, we need to calculate the exposure rate among the cases and exposure rate among the controls, odds ratio of exposure among cases, odds of exposure among controls, and odds ratio to test the strength of association between exposure and disease. It is an acceptable estimate of relative risk, and the incidence cannot be determined or calculated in case control. As well as we can calculate 95% confidence interval. Statistical testing for fitness or fit and independence using the chi-square testing for matching analysis, or we can use Makin-Marsh chi-square match paired analysis, or Mantel-Haenszel chi-square for multiple strata. These are all the tests that can be done in classical case control. Now we come to discuss an example for case control in which we use 2x2 contingency table, and we can see that we have in the exposure status the case and the controls and the total, and we can go over it. Calculating exposure rate among cases, for example, is 60 over 100 multiplied by 100 with 60%, and exposure rate among the controls, which is equal to 100 over 300 multiplied by 133%. And odds of exposure among the cases, A over C is 60 over 40, which is equal to 1.5. Odds of exposure among control, B over D, 100 over 200, 0.5, and then we calculate the odds ratio, as we can see, and it is equal to 3. 95 confidence interval, which is 1.88 to 4.783, and the chi-square tested is 22 with a p-value 0. We can use another software for calculation of the odds ratio, which is available in the following address of the website, the MedCalc. And also we can use for another software for calculation of the chi-square, as we can find it in this website address. We can use it for estimation or calculation of the chi-square test. And these are two important and useful softwares that can be used for estimation of the odds ratio, and as well as we can use it for chi-square testing In addition, we have so many software that can be used for these such purpose. Now we come to interpretation of the odds ratio. If the odds ratio is found to be greater than 1, then this is positive etiological association. If the odds ratio is equal to 1, there is no etiological association between the exposure and the outcome. And if the odds ratio is less than 1, there is negative association between the exposure and the outcome. And in some situations, the exposure, the risk factor might be protective from the disease. The advantages of the case control, the classical case control, is that appropriate for rare disease, and it is time saving as quick. We can enroll the cases in control within a short period of time, less costly, and we can examine multiple exposure of a single disease. And we need few subjects for the study. It means that we need a small sample size. Disadvantages is memory dependent, and this can result in information bias. We cannot calculate the incidence rate, as we need the population at risk and new diagnosed cases. Also, there is the disadvantage of selection bias, as we used to select the cases and the controls from the hospital according to specific criteria. Inappropriate for studying rare exposures and limited for examining a single outcome, and cannot study the natural history of the disease. Thank you very much.